Hey everybody, welcome back to the ECG of the day. My name is Reid, and don't forget that you can download the PDF for this ECG down in the description below and follow along yourself, make some notes for later. So let's go and get started. So first thing we're going to do is we're going to look at the forest. The trees of the forest are my QRS complexes, and so if I looked on here, maybe in lead 2, I see I've got a narrow complex rhythm. Seems to be somewhat regular. If you can tell, we've got these early beats here, regular, regular, regular. Then we've got another early beat, and then it gets regular again, and then kind of got this funky looking beat right there. Okay, my QRSs though are narrow, and when they are narrow, you can see that there are P waves before my QRSs. You can see the P waves better here in lead V1. They're always nice sharp P waves in V1. So my narrow complex rhythm makes me think that we've got, conduction going through the AV node down through a rapid pathway of the ventricles, and then there's P wave in front of it, so it makes me think that that's likely the case. It's a little bit of an irregular rhythm, so if you want, you could probably just measure the interval, from these QRSs to QRSs. If you want, we can do it a different way just to kind of showcase a different method of doing rate. And so what you can do is you know that this is a 10-second strip, and so you can count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 beats. So we have 12 beats over 10 seconds. If you multiply that by 6, so 6 of those 10-second strips in a minute, that would give you an average heart rate of 72 beats per minute. And if you want to just compare that to our normal R to R, it'd be kind of fun to see. Our QRS starts with a solid line, so 300, 150, 100, 75, 60, so maybe 65 beats per minute, right? So they're not perfect, but they're in the same ballpark, right? So it's just a good example of utilizing a couple of different methods to find your rate. At the end of the day, that doesn't really change management for this patient, luckily. And so let's evaluate what the atria is doing, right? What are my P waves? My P waves are upright in lead 1. And if you look real close in AVF, you can see that they are upright in AVF. All right, you see that little upright P wave in AVF. So that tells me that this is a sinus P wave. Okay. My PR interval, which tells me a little bit about my AV nodal function. For these P waves that are conducting to the QRS, my PR interval is less than 200 milliseconds, right? So in between 120 and 200 is normal, and that's good. And every P conducts to a QRS, right? V1 is really good for those sharp P waves, and it's really helpful because if you were to look for P waves that are on top of T waves, the T waves in V1, are typically pretty flat and broad. So you can see if there were any sharp P waves on those T waves, you would see. So we see we've got nice P waves, right? And so we got P waves, and as you can tell, in front of these narrow complex beats here, in front of these two funky beats, right here is one funky beat, two funky beats that are narrow. They're early, so these are premature, right? So they're premature complexes, but we need to make sure that there is a P wave in front of it, and you can see that there is a P wave in front of that, right? And the shape of that P wave is a little bit different from the normal P wave, just a hair, right? You can see it there too. And so these are premature atrial complexes, right? Or PAC, right? And we know that PACs are some ectopic focus in the atria that fires off, depolarizes the atria, and if we have a healthy AV node, and remember we're in that kind of that AV node evaluation period, the AV node should conduct that signal down to the QRS. Sometimes the PR interval actually is a little bit longer for PACs because the AV node has something called decremental conduction, meaning that the faster you stimulate the AV node, the slower it conducts, right? That's a safety mechanism so that we don't go into overdrive. We allow our ventricles time to fill. So you can actually see that PR interval gets a little bit longer because that PAC, just a hair, right? You gotta look really closely, just a hair longer, because in theory, the beat-to-beat rate of that PAC, the amount of speed that the AV node is being stimulated, is causing it to have a little bit of that decremental conduction. Kind of cool little details, right? And then if you look over at this premature beat, it's a wide, complex beat, right? You can see the QRS width is a lot wider than the normal QRS. And if you look in front of that wide complex QRS, I look for any P waves, right? You have to look on top of that smooth T wave to see, do I see any premature beats? Because we can have PACs with aberrancy, but we don't. So this is a premature ventricular contraction here. So we've got a couple PACs and a PVC. Let's evaluate our normal QRS complex. Our QRS is narrow. It's upright in lead 1, and it is upright in AVF. It tells me that my QRS is going down and to the left, which is normal. I've got good R wave progression. Here it's nice and growing. It maybe has early transition, but I bet you that lead V2 and lead V3 were probably poorly placed, but we still get good progression, right? We're going to look at our QT interval. I just kind of eyeball the QT. You can use R to R intervals. Look in the middle and make sure your T wave ends by then, which it does. We look for pathological Q waves or any ST or T wave change, which tells us if there's been any infarction. And I don't see any in any particular anatomic distribution. And so what do we have here? We have a sinus rhythm at a rate of maybe 65 to 70 beats per minute. We have 2 premature atrial contractions, and we have a single premature ventricular contraction. So I hope this helps. Nice little simple ECG, but it's good to know the common things and how to do it confidently so that you're not missing anything scary. So hope this helps. If you have any questions, put them down to the comment. Don't forget to like this video, subscribe to the channel if you enjoy this content, and we'll see you on the next ECG video. Have a great day.